Just so, hello everyone. Very good evening. My special thanks to Dr. Chopra for joining this webinar. Dr. Mattu will be joining us soon from the Central TB Division. And warm welcome to all our panelists who have a great deal of experience in implementing and designing the TB-PPM models in different settings. I'm sure we are going to learn a great deal of TB-PPM experiences from the panelists. I invite and warm welcome to all the IAPSM members. And we have our colleagues from McGill University, Canada. I welcome Petra as well. And before we start this webinar, I have two housekeeping instructions. We have, after the presentations, we would take the questions. Meanwhile, you can post your questions in the question answer section. And we would go for the panel discussions. And if you have any questions, you could post it on the question answer session. So without any delay, I would call upon Dr. Chopra to make the opening remarks. Over to you, Dr. Chopra.
Thank you, Dr. Shri. First of all, good afternoon to everyone who is watching this particular program and which is going to culminate into a panel discussion. First of all, I would like to congratulate Dr. Shri and Dr. Bhavesh for entering into a partnership to end TB from India. That's very, very important aspect. And tuberculosis is such a disease which is so dynamic in nature, and it has changed because having the experience of more than around 40 years, I have treated 4 generations of tubercular patients. So I know how tuberculosis diagnosis, management, and now even prevention is going to change. And it is very important that each one stakeholder has to contribute in this process. And IAPSM is a very vibrant and professional body. And if you ask me, we have members who are young postgraduates. We have members who are 60 plus. So if you count into the years, we have very young dynamic people who are passionate to work in the field and to bring about a change as far as the health of the people in this country is concerned. On the other hand, we have very large number of experienced people who have given 2 to 3 decades in the field, and they are the masters as far as the research is concerned, as far as the partnerships are concerned, as far as the implementation of the programs are concerned. And we have been partnering as far as this particular program is concerned. We have been involved in the certification process. IAPSM is already involved in 300 districts. And now since there are 650 medical colleges, and we have members from all medical colleges. And I personally have experience of sensitizing the private practitioner. And that is, again, very, very important. Why it is so? Because we conducted a study long time back to find out the treatment practices by the private practitioners. And you'll be shocked to know that there were 17 regimes which were being followed. What usually happens in India, once you pass out, there is no mechanism to provide you the newer knowledge which is there. And these kind of partnerships will help you to catch hold of all the practitioners which are there in all the cities, because TB is a notifiable disease now, but ultimately you will have to sensitize each and every person because TB involve all the organs of the body. So it is important to sensitize all the specialty doctors, and medical colleges could be one nodal agencies from where you can start in all the districts, depending upon how much scale you want to achieve in how much period of time. So IAPSM partnering with TB-PPM is a very, very welcome step. And I hope that together we will work at a very fast pace, because the target to eliminate TB is very, very near to us. So with these words, I give my blessings and congratulate both the partners who have come into the partnerships. And I wish to see that all the medical colleges and TB-PPM, they work together and they start working so that the sensitization of the private practitioners can be done in an effective manner, and whatsoever standard treatment guidelines are there for the tuberculosis, they are followed across the country. Thank you so very much for inviting me to this.
Thank you, sir. Thank you so much. We have Dr. Sanjay Mattu. Thank you, sir, for joining. So a brief introduction of Dr. Mattu. He is Additional Deputy Director General, Central TB Division. He is a senior public health professional with experience of over 28 years in the TB program. Earlier, he has worked as an airport health officer and has an experience of managing a public health emergencies of international concerns. He has also worked as in charge chief medical officer of emergency department of Lok Nayak Hospital, associated with Maulana Azad Medical College. Thank you, sir, for joining us. I would request you to make a few opening remarks. Over to you, sir.
Thank you, Dr. Vijayashree, and good afternoon to all. Please confirm if I am audible.
You are audible, yeah.
So once again, good afternoon, everyone. First of all, I would like to congratulate and thank TB-PPM Learning Network and IAPSM to organize this webinar on the role of engaging public-private providers engagement to achieve NTB target when we are seeing Indian scenario. So to go with what we are moving forward, India is having highly ambitious goal when we want to achieve the NTB target by 2025. Government is highly committed. There has been a clarion call by our Honorable Prime Minister, and our President also recently has launched a TB, Pradhan Mantri TB Pradhan Mantri TB Mukt Bharat Abhiyan. Okay, so that was launched on the 9th September 2022, and we are having this public, private, and community role is there, where we want to have their engagement at a very big level. So if we are seeing this Indian chapter of the TB-PPM Learning Network, it is an online community of a practitioner with a global secretariat present at the Research Institute of the McGill University Health Center, Montreal. The TB-PPM Learning Network have been created through a partnership between PPM Working Group hosted by WHO, BMGF, and McGill University, Canada. Then IAPSM has been a national level professional body in the field of community medicine and public health specialists. It has more than 6,500 members across India, and they are serving in medical colleges, various health institutions who are working in the field of research, training, epidemiology, and surveillance. IAPSM NTP core committee has been contributing immensely in the subnational certification process. They are providing support to NTP in awarding the districts who have made progress in decreasing TB burden, and they have achieved this subnational certification as per the criteria if they are eligible for a silver, bronze, or a gold certification. I'm glad to see that a TB-PPM Learning Network, India, and IAPSM agree to collaborate to the priorities related to the mid and long-term strategic goals of eliminating TB in India through PPM activities. I'm hopeful that this collaboration will focus not only on the TB-PPM activities within the gamut of NTP priorities, but also any other relevant health system area influencing the engagement of the private sector in TB elimination and produce knowledge products to facilitate peer learning. I also see an opportunity collaboration which will support to enhance the capacity of the stakeholder by holding the trainings, thematic workshops at the district level in the areas of the TB-PPM and by collaboration with the district tuberculosis officers. I urge that both the learning network and IAPSM to chart out a clear action plan by identifying experts, institutions working in the TB-PPM in India. The partnership should create a pool of experts from IAPSM and create a network using the social capital built by TB-PPM Learning Network to be able to connect with ground level NGOs and program managers. CTD cell extend all possible support for the collaboration to work together and convene to share the knowledge and build capacities. I would be interested to know about the progress made through the collaboration in the near future. We have very less time when we are seeing achievement of the NTB targets goal, which we want to achieve by 2025. But I am confident with collaborative and coordinating efforts from all the stakeholders, we will be able to defeat this dangerous disease tuberculosis. And by this, we will be able to say that we have defeated tuberculosis. TB harega, desh jeetega. I conclude my address with this, and thank you for providing me opportunity to participate in this webinar. Thank you.
Thank you, sir. Thank you so much. Dr. Bhavin, over to you for taking over the presentations. Thank you, sir. Thank you.
Thank you, Dr. Harivansh Rai Chopra sir and Dr. Sanjay Madhu for setting the stage and giving very appropriate overview about this collaboration. And now, after their opening remarks, as rightly said by both the opening remark stalwarts, the purpose of the collaboration is to establish mid and long-term strategic goals towards elimination of India through PPM activity and identify topics relevant to health system research, policy, strategy, and program implementation by working together between PPM and IAPSM. So I am sure this very prominent and expert panel discussion from different stakeholders will provide us some idea how to move forward. So to start with, I would like to request Dr. Swati Iyer. Dr. Swati is currently working as a WHO National Consultant PPM.
Dr. Bhavish, can we call upon Dr. Ramya first? Because she has to start it live. Yeah.
Fine. Sorry, Swati. Yeah, so I think we are starting with Dr. Ramya Anand Krishna. Dr. Ramya is our own community medicine graduate from Sri Ramchandra Medical College, Tamil Nadu. She has more than 2 decades of experience in working at various levels in medical college as well as National TB Research Institute and this public-private partnership along with community. She is working for the organization known as REACH. They are working with Stop TB Partnership, Global Fund, USAID Call to Action. She has also supported technically for Union Operational Research course, and she has vast experience of working with community, not only in Karnataka, but I think entire South India and also a big project in TB Free Chennai. So I invite Dr. Ramya Anand Krishnan from REACH India to deliver her talk about engaging private providers in the PPM TB. Dr. Ramya Anand Krishnan, please. Is she there, Dr. Vijayashree? I am not able to see. That's why I started with Swati. She's a. Please unmute yourself. Vijayashree, please unmute yourself. I think Dr. Ramya is at airport. There are some technical glitches. So while she connects, I think we will go back to again Swati. Dr. Swati, she's a WHO National Consultant for Public-Private Partnership. Earlier, she was working as a WHO medical consultant in Haryana, Delhi in NTEP. Also, she has worked for Japaigo for maternal and child health project. And Swati is also a community medicine graduate from Shared GS Medical College and KM Hospital. So I request Swati to take a session on policy changes in NTEP to engage private health sector players. Dr. Swati Iyer, please.
Yeah. Thank you. Thank you, Dr. Bhavesh. I'll quickly share my screen. Is my screen visible?
Yes, make it full screen.
Okay, yeah, I'll do that. Yes. So the session that I'll be taking now is on the policy changes to engage with the private health. Before we move on to actually understanding what the policy changes were, I would like to give you a brief background. So when we say private health sector players, it can broadly be classified into two. One is the private healthcare providers who are directly dealing with the patients, giving them diagnostic and treatment services. That is one part. There also are other private health sector players who do not provide such services directly to the patients, but they are there to complement the existing health systems. Let's say in case there are gaps that we feel the existing health system cannot fit in, we have these players who can support us. So when we talk about partnerships, these are broadly the two areas that we see partnering in. So first, we'll talk about the healthcare providers who actually give care to the patients in terms of diagnosis and treatment. So when we talk about the policy changes, there are you can see the list here. So we'll go one by one in the subsequent slide. So the first is the Gazette notification. So okay, so we'll start with the Gazette notification. The aim of this notification is to reach out to all the patients. So as we know, there have been times when, there are patients who have symptoms but may not be reaching out to doctors. In case they reach out to doctors, for some reason, they are not being notified. So there came this Gazette notification to ensure that each and every TB patient who's diagnosed is brought into the health system. So you can see there have been many modifications and amendment to this notification. It started in the year 2012, then 15, then 18. But broadly, to understand what is there in the Gazette notification, the key words are mandatory notification. By whom? Laboratories, practitioners, hospitals, and chemists. Along with that, there's another component of public health action. For those who don't know what public health actions are, in case of NTEP, public health action means once a patient is diagnosed, there are other services that a patient gets, which could mean that he will be given access to free diagnostics, free treatment. Then there are adherence services, follow-up services, long-term follow-up services, comorbidity screening, so on and so forth. Apart from that, there's another option of self-notification. Now, in case there's a facility or a doctor who notifies or diagnoses a TB patient but doesn't notify. So what happens? There are certain services that are available for that. So when we talk about IPC 269 and IPC 270, so the keywords here are negligent and malignant act. What is the difference? Negligent means that there is something that as a doctor you are supposed to do, but you are not aware of it and you don't do it. That is negligent. Malignant is where you know you are supposed to do it, but you still don't do it. So these are the two acts under which a doctor who diagnoses but does not notify can be punished. The second is just a moment. Yeah, so the second is the Medical Council of India Code of Ethics. So under which, again, as you can see, anybody who's engaged in the public health work should enlighten the public concerning quarantine regulations and measures for prevention of epidemic and communicable diseases. So again, most of us have been a part of MCI, right? So our duty as a public health expert is this: prevention of epidemic and communicable disease. So any physician should notify the constituted public health authorities for every case of communicable disease under his care. The third is the Gazette ban on the serological test. So there was a time when serological tests were used to diagnose TB. Now, because of its inconsistencies and imprecise results, it basically led to wrong diagnosis. So there was a Gazette notification that said that these serodiagnostic test kits should not be used for diagnosis of tuberculosis. The next is Schedule H1 notification that was issued by the Government of India in 2013. Now, what does this say? There is a list of drugs that is given, which are called the Schedule H1 drugs. For those drugs to be sold, there has to be a prescription. So that's one part. Once there is a prescription and the chemist dispatches those drugs, there is a register where the details of the patients and details of the doctor who is prescribing those medicines needs to be noted down, and on a monthly basis needs to be shared with the drug inspector. Now this again, because I'll side by side keep talking about SNC because IAPSM is such a key partner in conducting that. This is very important because the moment we know that this sort of a format is being maintained, is being filled, and is being shared, we can exactly know how many drugs, rifampicin containing drugs, were sold in that district. And similarly, because this format also captures the details of the patients and details of the doctors. So you can reach out to these patients and these doctors can be contacted in case they did not notify the patient. So you can see our anti-TB drugs are in this list of Schedule H1 drugs. The next is Clinical Establishment Act 2010. So under that, the keywords are provide for registration and regulation of all clinical establishments in the country with the view to prescribe the minimum standards of facilities and services provided by them. Next is on DrTV and ART services that should be a part of the medical colleges. So last 2-3 years, there has been a lot of, everybody's talking about setting up DrTV services and ART centers. Now, why is it that is there? Medical colleges are tertiary care hospitals where not just in terms of infrastructure, but also in terms of human resources, you have all the specialists. So if all the medical colleges have a DrTV center, have a ART center, then it will be of great support to the program. So we did talk about the IPC 269-270. And of course, if you do not follow a certain rule, there are repercussions. But the question is, do you need to use them? So before you actually apply such measures, one must understand the concerns of all the stakeholders and then accordingly take a step. You take one step like that, there could be repercussions. So it has to be thought through in its entirety. That was one aspect till now that we spoke about. The second, in the partnership between government and private healthcare providers, we under NTEP constantly talk about free diagnostics and treatments. So once you come across any healthcare providers, or maybe some of you who have private practices, if you have someone of presumptive TB, under the program, there are provisions for free diagnostics under which the NAT facilities will be provided for free. The patient remains with the doctor. It's just that for diagnosis, no out-of-pocket expenditure will be there. Similarly, when we say free treatment services, that does not mean that the patient now will come to the public sector. No, the patient remains with the private sector. But if wanted, the free FDCs that come under the program will be supplied to these health facilities. So that is another kind of partnerships where there is no financial implication per se. It is not that a doctor will be paid if he does free diagnostics, but it is a mutual understanding between the public sector and the private sector. Now, this was all in terms of the first category that we spoke of, where there are doctors who cater to are patients and they are from the private sector. That was the first part. Here we come to the second part where there are other health sector, other private players who help us in complementing the existing services that are being provided in the public healthcare system. And yes, of course, to explore newer avenues, innovations, evidence synthesis, etc. So giving you a brief background, going further in the next sessions, you will have people talking more about the partnerships and what are the various options that are available. But just to give you a brief background, there have been multiple such guidances that have been given from the center. So right in 2000, 2001, there was one document that along these options that have been given in the bullet, along those options, partnerships could have been done. Then in 2008, there were again some modifications to that. Then 2014, another, and now we are with the 2019. That is the most recent document that we have, about which we'll be reading in detail now. So what exactly is the change? The first change is in this partnership guidance document that was there is that from grant and need, now we have moved to output-based contract. Now, what is the meaning of this? Grant and need is like a lump sum amount is given, and then the results we get. So depending on the results, the money is not defined. So the money will be given upfront, and then the results have to be brought out. As against the output-based contracts, where how much you are paid depends on the output that you get. So this has been a major change through the partnership options that have been there. Then prescribed cost to market discovered rates. There was a time when it was said that, okay, if you're doing X-ray, maybe 200 rupees. But now what is being advised is for every district, do a market scan, see what are the available options, what are the rates that prevail, and accordingly decide. So for example, X-ray in Mumbai could be different from X-ray in Patna, could be very different from to X-ray in a smaller city or a village in Haryana, for example. So market discovered rates is it was a new change. It was a principal level change that was brought into the partnership guidance document. Next, it's actually the key thing here that instead of guidelines, it is a guidance. It tells you that these are the options. Nothing is hard fast. You have to amend everything as per your situation. It is need-based and patient-centric. Now, below you can see various steps that are actually that one goes through in the phase of contracting, but we'll mostly be talking about the first, need assessment, and the last, performance monitoring. Not the payment part, but performance monitoring. Why? Because as IAPSM members, as community medicine pass outs, our technical expertise lies in these two key areas. So what is need assessment? Now I'll talk in terms of NTEP, obviously. So identifying the gap in the key output indicators. So you know that under our program, there are a few indicators. That's how we define. So like notification could be one, HIV screening, DST. So there are multiple such indicators. So you identify what are the gaps that are there. Now, the next step is once you know, for example, if you know that, okay, for my district or maybe wherever your medical college is, if for that the notifications have gone down, then you dig deeper into it as to why did the notification go down. Was it because I did not test many? Was it because I did not refer many patients? There were more patients who were presumptive, but I did not refer them. Was it because I actually referred adequate number of patients, but I did not have, or maybe I referred enough, I had a machine, but I did not have an HR. So digging deep into the whys of those notifications is a step 2. Step 3, again, as I've anyway covered it in step 2, which is identifying the gaps in infrastructure, consumables, human resources, etc. Now you compile all this and you will have like a long list of which are the gap areas that you have identified. But the next step is you prioritize which are the ones that you immediately want to act upon and make a partnership on. And after that, based on whatever you have prioritized, next thing we do is have a partnership based on that. So these are actually the options that are there in the newer partnership guidance document. I will not get into the details, but what you will realize is that these options that are given are exactly what happens in the patient care cascade, except the first one, which will be taken in depth by Dr. Bhavin in the next few presentations. If you see, a patient is notified, so it has to have diagnostic services, perhaps treatment services. For diagnostic services, you need someone to collect the sample and transport the sample. So then only diagnosis will happen. Once diagnosis is made, then public health action needs to be there. Let's say there are drugs that are available, but now they need to be transported to the patient's home or the clinic. So their drug access and delivery services would come. You must have heard about active case finding, where we go in the community and actively search. So if we feel that we need a third interface agency, a third organization to do this, that is again something, that's again an avenue where we can have partnerships. Then TB prevention. Earlier, for TB prevention, we would give chemoprophylaxis only to PLHIV and under 5 children. Today, we have expanded. Now we go to all the household contacts of pulmonary TB cases. That is also microbiologically confirmed. So now we need to deal with more number of people. So there is a chance we may need more hands. There's a chance we may want to have another agency who can help us with TB prevention. And last but not the least, ACSM. So community empowerment, community engagement, because these are the activities that constantly go on in the background. And if you feel that maybe your organization, or maybe the district that you belong to, the district where your medical college is, if along the care cascade, if there's any point where you feel that the current health system may not be able to cater it, there are partnership options. All you need to do is do a good need assessment and accordingly find out new partnerships. So this I've anyway explained. PPSA, just in short to tell you, it's end-to-end service. So right from engaging a doctor, mapping, engaging, and then giving him the diagnostic services. So then you notify, then you treat. So along the care cascade, from first point to the last point, when in the entirety, everything is done by one agency, that is called PPSA, that stands for Patient Provider Support Agency. So that was the need assessment part, and accordingly finding out which are the areas where you need to have a partnership. Once the contracting is done and now you have an agency in your district or maybe in your college, what do? Monitoring and evaluation. So again, it's very important. Most of us, most likely what happens in the program is that when the payment has to be made, there will be validations, but monitoring at fewer frequency, like let's say maybe weekly or fortnightly, that sort of a monitoring is very, very important so that the corrective actions can be taken. And because you, my friends, have a lot of expertise in this, I would request that again, this is another avenue where you can get involved in the program and get and partner with us. That's it from my end. Did I overshoot the time? Hello.
Thank you, Dr. Swati. Appreciate your presentation, giving glimpse of the entire new updates in the policy. And it is, we have one, my minister used to say, we should have a IPC or the laws, but we should not need to use it. So I think in TB also we are going in that direction, that this end-to-end solution, starting from awareness or engagement till monitoring and evaluation. Thank you, Swati. Now I welcome Dr. Ramya Anantkrishnan. As I said earlier, she is our own MD Community Medicine from Sri Ramchandra Medical College, and she has more than 2 decades of experience working at grassroots level with community. So without wasting much time, I request Dr. Ramya to please proceed with her session about engaging private providers in PPM. Thank you, please.
Dr. Ramya, we can't hear you.
I think we have lost her.
Yeah.
Can you share? Are you sharing your presentation or she doing it herself?
No, Dr. Petra is doing.
Okay.
Dr. Ramya, we
Okay.
can't hear you. Yeah.
She's not connected. I think she got disconnected.
Okay. Yeah. Do we move to Dr. Mishra in that
Avish?
case? Yeah. Dr. Mishra, Dr. Balakrishna Mishra.
Okay. Thank you. So I'm happy to introduce Dr. B.K. Mishra. Mishra sir is a state TB officer of Bihar, and he's, I think, one of the rare combination who have experience of starting from the grassroots level, from MOTC till WHO consultant, as well as now state TB officer. He has also worked, contributed for establishment of IRI laboratory of Patna. Because of Sir's experience, he is also implementing BMGF supported project of patient provider interface agency in more than 14 districts out of 38 districts. So I invite Dr. Mishra sir to share his experience of PPM implementation in the state of Bihar. Dr. Mishra, please.
Thank you for
Sir, we are not able to hear you. Mishra sir, your screen is
giving this
visible.
opportunity to, yes. So just because our Honorable Health Minister is taking the physical review meeting, so I have taken time to come very much short. If you can share the slides, it will be easier for me to give, because most of the things Dr. Swati and other colleagues have covered. After 2019 internship guideline, the things moved to the country, and we are so can you share the video? Yeah, this presentation slides.
Yes, we can do that, Dr. Mishra.
So basically, you can see that we have 19 districts private sector engagement. For 2020, we started with 14 districts, yellow in color, and recently encouraged with the result, whatever came from the 14 districts, we floated the tender for another 15 districts. But somehow we got the 5 districts covered, the blue in color. So what Dr. Swati was telling about the need-based and performance-linked, not the grantee-led system. So we have identified TB identification, testing for HIV and blood sugar, sample collection and transport.
Dr. Mishra, you're not audible at all.
Yes, I am. I can listen you.
Probably we'll have to move to a
So,
place which has a good network.
No. Can you share the slides? I was,
Yeah, we can share the slides, but we can't hear your voice.
yes, sir. Now,
Yeah, it is better. Please go on, Dr. Mishra.
okay, so speaker on. So now the other areas are seeding of the bank account for giving the Nikshay Poshan Yojana and the treatment adherence and reporting and their outcome of the treatment. So right now we are giving 60% of the claimed amount. We try to pay within a month or 15 days. And 50% after validation. At times it takes the time also. So this is still a challenge, but very soon we will be having our IT tool based so that the accountability can be fixed at each level, and we want a seamless payment to the PPSA partners. So next slide, please. Okay. So video because of the internet issue so that you can hear me. Okay, so the previous slide, please. Can you show the previous slide?
Dr. Shri, you can project the
Yes.
slide. Dr. Mishra has switched off his video so that he'll have better bandwidth. and
Yes,
so that
yes, I have switched
more
off.
audible.
So
Yeah.
now you can, yes. So now this is the slide where it's important to realize us that how important is the private sector in the TB elimination program of the country. So you can see we have given the TB notification just because the first of the thing, the TB notification gives that the knowledge about the TB patient comes to the health system so that the other public health actions as per the Indian standards of TB care reaches to the patient. So you can see that we
Dr. Mishra, the connection seems to be
Yes.
very bad. We can't hear you, Dr. Mishra. If you can switch off the video and make a oral presentation, that would be appreciated. We can't hear you at all.
Yes, I have switched off. So you can see here that the TB notification 21 from the private sector. So the blue line is from the public sector and the red line in the private sector. So it has crossed, and right now it has given us the better presentable face at the national level also, because you can see in 2019 the TB notification gap at the India level was 84 and ours were only 58%. But the things have changed now. After 2021, you can see India achieved 72% of the notification, and we also reached the 70% of our target. And this time till October, our TB notification rate is so 84%. So next slide, please. Next slide. So this is something that has encouraged us, and we want to cover the other areas of services like programmatic management of TB preventive treatment. So next slide. Yes. So here also you can see that how after 5 districts more. So earlier it was lockdown period, peak of the lockdown, we started our project. And then the second lockdown in the May 2021. But still we dared to implement the PPSA in the more 5 districts. And after 5 districts, you can see the red color private sector notification has how much shooted it in comparison to the public sector. So it's a wonderful that if we able to select the good PPSA agency, or anyhow, it is not limited to the patient provider support agency. There are many other reasons how to get the private sector. So next slide. It is not only the notification, rather we can see the bank account seeding. So till 2000, you can say that from the private sector, the patients who were notified from the private sector, it was only 48% of the patient whose bank account was available to us. And that's why they were not getting the Niche Pochon Yojana benefits. But the things have changed now. So you can see that in 2022, so private sector, we are getting the complete bank account detail more than even the public sector, 84% versus 71%. It's another matter that how we will respond to these account numbers, how much we are paying, so that we will discuss later on. Next slide, please. Yes, here the HIV status and blood sugar level. So the major comorbid conditions that affect the treatment outcome is the blood sugar and diabetes and HIV. So, well, you can see that before 2020, the public sector, here it is the red color, and the private sector in the black color. So we can see here.
Stop somewhere here?
Yes, it's shown. Someone can confirm from the participant. I can see the graphs.
Yeah,
so,
it is.
So now it has shooted to 89%. So 89% of the TB patients who are notified from the private sector, they are getting HIV tested. And that's wonderful that they can be, those people who are HIV positive, they can be linked to ART center. The same way, blood sugar testing, earlier it has been, say, in 2019, only 38%, but this 38% blood sugar testing has been increased in the private sector to 86% in 2022. So blood sugar, we are having the very much blood sugar is the problem. So diabetic patients are started on the anti-diabetic treatment also. Next slide, please. So you can see here the treatment success rate. So earlier in 2019, the treatment success rate in the private sector was 83% and public sector it was 77%. But now it's increased in the private sector 84%. So in no other part of the country, I think that this kind of result of treatment can be seen in private sector. So it's a good that whatever, there will be the different ways of engaging with the private sector, maybe directly, maybe through the patient provider support agency, but it's wonderful to engage with the private sector. We cannot think of TB elimination without engaging the private sector, and we require to work together. So next slide, I hope it's the last one. So this was because I'm in a hurry, so but still I can take some questions if you have.
Dr. Mishra, thanks for this presentation. I will move over to Dr. Ramya, and then during the panel discussion, if there are any specific questions, I'll get back to you.
Okay,
thank you so much.
Thank you
so much, Dr. Mishra. Dr. Ramya, welcome. I understand that there are some internet issues. Welcome. And Petra, could I request you to please operate her slides from your side? Thank you. Over to you, Dr. Ramya.
Yeah, thank you. Thank you very much, Dr. Vijayashree. Can you just confirm whether you can hear me?
Yeah, I can hear you very well. Yeah.
Okay, thank God. Yeah, and many apologies to everyone. I really had a very bad patch of connectivity. Again, I'm very delighted to be in this meeting, and thank you for this opportunity to speak to you about private sector engagement. And I'm going to be talking about a model which we began in Chennai about 20 years back. And in fact, this was a model which we developed through our first Global Fund grant in 2003. And then it amplified and was scaled up through the TB Free Chennai initiative. And the findings of this helped feed into the national policy, into the partnership option documents, which was presented by Dr. Swati and which is going to be presented by Dr. Bhavin. And also, I think in many of other discussions, the findings have helped feed into that discussion on public-private partnership. Next slide, please. So very briefly, we are an organization with two major core strengths. One is working with the private sector, and second, working with the communities, especially affected communities, and empowering them. We also work with different groups of stakeholders, and today we work across the country in more than 30 states and union territories. Next slide, please. Very briefly about the private sector engagement model in Chennai. So one of the key things when we talk about private sector engagement is the branding of the engagement itself. And I think branding this as Nakshatra model really helped create a value to this public-private partnership. Today it is very widely known as the Nakshatra model of private sector engagement. The key aspect of this engagement is that when we engage with the private sector, it was the entire spectrum of private sector, which includes private practitioners, chest physicians, general practitioners, and also the private laboratories and the pharmacists. So pretty much every place where a person with symptoms would go to in the private sector, all these different players were mapped and engaged. And that was very unique to this Nakshatra or the private sector engagement model. We created centers called the Nakshatra centers, and this was mirroring the tuberculosis units which are present in the public sector. So as all of you know, there is a tuberculosis unit in the public health system. So we mirrored that to have these Nakshatra centers in the private sector. And this entire concept of private sector is building on private linkages, where all of us know that, let's say for OG practitioners or surgeons, while they have private practice, they tie up with another private hospital for their surgeries. So very similar to that, we have actually created a private linkage rather than a public-private linkage because we feel referrals and movement of people works better within a specific sector, and that is what we've leveraged. And also a key part of this is that people are provided a holistic care and support, both the patients and their families. The key services which are being provided in these Nakshatra centers are access to free chest X-ray, free gene expert, a risk assessment, and of course, free drugs from the public health program. And if you can see this model, all of this, the drugs, the diagnosis, everything comes from the public sector, and the people with TB get access to good quality diagnosis, good quality treatment while being in the private sector. Again, another aspect of this model is that we don't interfere with the consultation fees of the practitioners, which is very important because seeing patients is definitely the bread and butter of the doctors, and we don't want to build a model which sort of takes it away. And that's why we moved away from requesting private practitioners to refer directly to the program, and also to respect the choice of the patients, because any patient has the right to go and seek care either in the public sector or in the private sector. But irrespective of the sector, they need to have access to good quality diagnosis and treatment. And that is what this whole model leveraged. And I think what was also interesting is that pharmacists and laboratories also played a key role in this overall private sector engagement. Next slide, please. So this is a network for care. As you can see, the Nakshatra Center is pivotal to all our activities, and you see this very tight network created between a person with TB, between the practitioner, between a private hospital, laboratory, and these centers are spread across the Chennai city. We have about 40 centers currently. Next slide, please. So very briefly about the results between 2017 to 2022, we've been able to reach out to more than 50,000 people with symptoms of TB, and we've been able to provide close to 30,000 free CB-NAT testing. So when we provide these testings free of cost, we also help the people with symptoms of TB to complete the diagnostic and care cascade. And that is what is very challenging in the private sector. We've had a fantastic percentage of initiation, close to 99%. And in all, about 1,000 plus PPs were engaged. If you can, even though we engaged 1,000 PPs, and if you see the 50,000 referrals, what is very interesting is that 80% of our referrals actually just came from about 60 to 70 practitioners. And these are the low-hanging fruits in terms of chest physicians and general practitioners who are in major tertiary hospitals. But then what it also shows is that if we are to end TB and if we are to look at universal coverage, to reach the 20% of the people with TB, we have to reach to a large group of private sector doctors. And that was a key learning here. And so we've supported the NICSHI notification, and today we contribute overall in Chennai city about 70% to 75% of the total private sector notification is through this partnership model. Next slide, please. So in terms of the profile, what is the type of people who come to the private sector? And this may be true of any private sector engagement models. 45% of our people with symptoms of TB and people with TB are women. 7% are pediatric, and 5.5% of our people with TB are children. And again, this is very unique, which we don't see in other models, is that more than 50% of people with TB and 70% of our pulmonary TB are microbiologically positive. So we not only help practitioners to diagnose TB, but we also help them to diagnose them in the correct way. And of course, most of our people with TB, which is true of any setting, public or private, 63% are pulmonary TB. Next slide, please. So in terms of key achievements, we have been able to increase the contribution of private sector in a very structured manner. And today there is an active participation of close to 1,000 plus private practitioners, a very high bacteriological confirmation, and a treatment outcome of close to 90%. And again, contact screening, because today the country itself as a whole is looking at TPT and latent TB infection treatment. So the uptake has been quite challenging, but it's slowly increasing. Next slide, please. So in terms of the total out-of-pocket expenditure, which has been averted to a person with TB, close to 8 crores because people with TB were provided free gene expert, 0.5 crore because of free x-rays, another 4 crore worth of free medicines. So totally we were actually able to avert about 13 crores of out-of-pocket expenditure to people with TB. And for us, for this model, the average cost per person with TB identified is about 2,900. Next slide, please. So in terms of the incentive, this is in terms of key learnings, this is a non-incentive model. We don't give incentives to anybody. And again, there is a huge commitment from the private sector, and especially today, because of the branding, many hospitals come forward and want to become Nakshatra centers. And in fact, the Chennai model has been highlighted in JMM report, in NSP reports, etc. And again, we've also been able to provide access to DRTB drugs, social support, give them access to uninterrupted drug supply and adherence support also. Next slide, please. Hello, next slide, please. Yeah, so thank you. And I think what I just like to leave away with is private sector engagement is very important and very critical, and one size will not fit all. So we need to find different ways and means of engaging them. And I think that's where all of you play a very critical role, because I think what you're seeing today are a few models, few ways of engagement. But I mean, we could look at social business models, venture capital models, so many things are out there which can be leveraged. And this is not only applicable to TB. From TB, we could also move to other public health challenges also, using and leveraging the private sector, the huge presence of private sector. So thank you very much, and over to Dr. Vijayashree.
Thank you, Dr. Ramya. Very nice, very useful presentation. Thanks for taking out time from your busy schedule. I have one question. In fact, I was planning to take this question in the panel since you're leaving. So what are the suggestions, Dr. Ramya, how this IAPSM and TB-PPM Learning Network could contribute to the implementation of TB-PPM, especially from the perspective of NGOs?
So I think there is a scope, one in terms of understanding the baseline, the baseline profile of the private sector itself, and understanding the gaps, mapping the area, looking at where the gap is in terms of missing people with TB. And I think especially when you look at medical colleges, it's also very uniquely set up, because there is a technical support which can be provided by the general medicine department, or surgery department, or ortho department. Then we have the whole program support which can be extended by the community medicine department. So we can leverage the different departments, especially in medical college setup. And again, that's something which private sector usually looks forward to, getting second opinions. And see, as long as they retain their patients, I think that's fine with them. So, and this is where they can come in, and of course, DRTB and again, especially PSM, they have a huge road ahead, not only in terms of the actual helping people with TB in treatment adherence, but also for post-treatment follow-up. What is the kind of quality of life that people with TB face? And again, how can that be supported? Can we have rehabilitation clinics, pulmonary rehabilitation clinics, so on and so forth? So I think there are many areas for synergies and collaborations, and between IAPSM and NGO and the private sector.
Okay, thanks, Ramya. In terms of learning, that's something we would like to have your suggestion, and maybe during the panel discussion, I may like to call upon on you again. Thank you, Dr. Ramya. Now I move on to Dr. Bhavin Vadera. He's a public health specialist with more than 1 decade experience. He is currently working as a project management specialist at USAID. He has been heavily engaged in drafting of this PPSA partnership guidance document, and has played an important role in scaling up this PPSA through domestic budget. Dr. Bhavin, over to you. Yes, Bhavin.
Thank you. Thank you so much, Dr. Vijayashree and IAPSM team, Dr. Bhavesh, for inviting me on this panel. I'll straight away jump to my slides and the presentation on the PPA partnership guidelines. So broadly, can you see my screen?
Yes, Dr. Bhave.
All right, sure. So broadly, I have put together the content into the, first of all, about the PPASs and various PPP models. Dr. Ramya already had shared one of them. And then the next sets of pointers that I've tried to include is broadly to indicate how the IAPSM and the community medicine department can contribute, and we can work together on these area of PPP in TB. So starting from the slide which was ended by Dr. Swati, right? So in the 2019, there is a broad strokes of partnerships related guidance being put together in the document, and that covers a range of partnership options. You can see right from the community awareness till the patient's care and post-treatment care, as well as supply chain and other program management related aspects. But I'll speak more in detail about the PPASA, which is the core topic here. So the PPASA stands for Patient Provider Support Agency. It's basically, as you can see, this is an agency which works on 3 different points. One is, of course, persons with tuberculosis. Second is private healthcare facilities. And then third is, of course, for the National TB Elimination Program. So the agency's work is to work with the private healthcare facilities, provide dedicated skilled people, more or less like medical representatives. They engage with the private healthcare providers, motivate to follow the standards of care. They inform about the latest updates from the World Health Organizations and other global evidences on the tuberculosis care. And then not only they advocate about it, but then they support to so that the private providers can execute the standards for care, right? Second, they work with the National TB Elimination Program. So they establish linkages, say for example, on sample transportation, drug supply, recording and reporting matters related with the NICSHI, so that the linkages with the government can be established with the private healthcare provider. And then finally, they provide dedicated people who work with persons with tuberculosis on the aspects of counseling, compliance support, nutrition linkages, and all the follow-up activities which is required to complete the public health action, including nowadays the preventive aspects of it as well. So this covers the entire package of services in PPASA. So this PPASA was devised over the years, and many of the panelists, the speaker who are here have been engaged in this. On the right side, you can see, right, it started from an interface agency initiative in 3 areas, which includes Bihar, Patna, Mumbai in Maharashtra, and Mehsana in Gujarat. So where this interface agency concept was introduced, where drugs and diagnostics were provided free of cost, there were specialized staff who were engaging the private healthcare providers and dedicated staff for providing the public health actions. Over a period of time, there were other initiatives like mentioned by Dr. Ramya, Nakshatra, Thali. There are other 40 city initiatives. They were all culminated and providing interface agency related activities in a different forms. By learning those initiatives, in 2017-18, the Global Fund supported initiative known as JEET, and which was taking the learning from the interface agencies, plus some of the things which can be adjusted with the NTEP. So let's say, for example, laboratory services, drug supplies were done from the government side and not from the private side. And from 2019 onwards, the government has taken up this through the domestic budget. Now, Government of India and the state governments funds these interface agencies across country. You can see on the left-hand side, the graph of notification from private sector. It has increased 7-fold since last 5-7 years. Now we are almost notifying 7 lakh patients from the private sector. And the achievement doesn't stop at only notification of patient. And that's the most crucial part of this all initiatives, which is now culminating into PPSA, is that after notification, right, the testing that need to be conducted as per the current recommendations globally, which is, molecular testing, drug susceptibility testing, the treatment part that, whether it is a DSTB or DrTB, they can be provided from the public sector as well, free of cost. Then adherence support, the HIV testing, diabetes testing, as well as finally treatment outcomes. So we know the full range of care of all these people who are seeking care in the private sector, and doesn't stop at the only notification. So that's the wholesome approach which has been included in these PPSAs. As we move forward in this journey, and many speakers also spoke about it, right? That one shoe doesn't fit all, right? So as you can see, the PPSAs are one piece of it now. In more than 250 districts right now, it has been implemented. But beyond that, state have started now taking initiatives, and this is where, from this point onwards, the IAPSM team can start thinking, start working with the states when they are innovating. Okay, so Rajasthan has started to put the similar kind of a concept, but they are not hiring a third-party agency, but all those small initiatives and incentives which are linked with those initiatives are directly given to the private healthcare providers or their assistants. Okay, so this is known as patient provider incentive scheme, where the direct incentives and the money for each of the activity which I spoke about are given to the private healthcare provider, and the private healthcare provider's responsibility to make sure that all of these services are provided to the patients. In other states like Kerala, Karnataka, where they are establishing a model where private healthcare providers, largely the major hospitals, they identify a nodal person within their health facility who takes care of this entire care cascade of persons with tuberculosis, and to ensure that such kind of centers run and perform. They have set up a consortium of private hospitals. They have a coalition of the professional medical associations who meet every monthly to make sure that the private healthcare providers are taking this initiative in full spirit. Similarly, in Tamil Nadu, they are in an initial stage to set up similar kind of a model. Plus, they have set up some learning hubs, recognition processes, as well as consortium, which includes district administration also. So this is how it is evolving, right? The PPSA journey evolves from the UATBC, where the interface agencies were there, and now the states have started taking their own ways, to make sure that the patients who are seeking care in private sector are getting the full range of services as been prescribed in the standards for TB care in India. The next few slides is dedicated for the IAPSM members. Yes, there are initiatives which has been planned by the developmental partners and funded by donors, but as we have seen, there are a lot of scope of improvements, and state have started realizing it and started moving it, right? So I'm just giving a glimpse of 2020-22 data over here, and you can see there's clearly the scope of improvement where in each of these area, either the PPS agencies or the states, or with support from learned faculties from the community medicine, can support to improve these performances. While this is a core performance programmatic targets and indicators that can be followed, in addition to that, there are certain things that you can work with the district TB center locally and try to identify it. I'm just highlighting few of them. Whether the coverage is full, whether all the patients who are there in the private healthcare sector are covered or not, and how to do it. Okay, what are the things that we can improve upon so that this can be improved? Turnaround times of test results. The private healthcare providers always give the quality and in time. Okay, but many a times because of the workload and many of the other priorities that the laboratory technicians give to other tests, the turnaround time are not managed, right? How to deal with that? Is there any gaps in the sample transportation? Is there gap at the efficiency level of the laboratory functioning that we can improve upon? Timely availability of the drugs, right? We commit to the private healthcare providers that we will provide free anti-TB drugs. But at the end of the day, if they don't get it in time when they require, then that trust factor, which has been built up over a period of time, can be broken and the things can go haywire, right? So how to improve those timelines about the drugs management and supply. Treatment adherence support. As in many of the earlier presentations, as well as in my presentations, you can see that almost 30–40% of the patients we are notifying from the private healthcare providers. Now, to manage the compliance of these patients on treatment for 6 months is a humongous task, right? So how to do that, how to innovate there and improve these processes. And then finally, reduce the out-of-pocket expenditure. Currently, though we are engaging through the PPSAs, through the interface agencies, but you have seen that it works in limited number of geography, almost half of the country, but still there are half of the countries where the PPSAs are not there. And even where the PPSAs are there are gaps in terms of providing these services free of cost. So how to deal with that so that we can reduce the out-of-pocket expenditure for the patients who are seeking care in the private sector. So this is one piece where we can work together in terms of improving these factors, at least at the district level, at the local level. Some of the areas I have just, straight away put together, which our faculties and colleagues can help the district TB officer with. One of them is, skill building needs, right? Though there are PPSAs, though there are agencies who are working there, and there are districts where there are no PPSAs, okay? So we need to work with them and improve their capacities on the counseling part of the patients. Prioritization approach, okay? There are thousands of healthcare providers, whether we need to include or engage everybody, or we should target some key healthcare providers in order to increase the coverage, as well as in order to improve the care in the patient, care for the patients. Scheduling of the visits, okay? PPSA do engage with them, but whether the scheduling are designed and worked in such a way that they can engage the key provider more frequently, and they can also cover the other providers at a lesser frequency, but on a regular basis. Communication management, okay, whether it is in person or in group, we can work out what are the areas that there are gaps in the communication to the private healthcare providers, and how can we improve upon. Feedback. We are nowadays getting feedback, even the services that we are getting very regularly from the government side, whether it is electricity, whether it is gas services, or any other services from the corporate sector. We usually get feedback, what is the utilization of those services, okay? Similar kind of service, the feedback which we can provide to the private healthcare providers, and you can help the districts to design those kind of the feedback which are more professional and nudge those last mile gaps which are there in management of the patients. Some of the areas you can only help them with the area of privacy, confidentiality, gender sensitivity, inclusivity. These are the areas that, in this model world of public health, we need to be very cognizant about, and we need to make sure that even if we reach at a mass scale, these areas are well covered. And I think these all skill building areas that, community medicine can very well help with. Finally, learning and evaluations. So documentation is very key. There are many initiatives that is even happening today in your district, but these are not well documented. And this is where, again, the community medicine colleagues can come together and help the TB program and the district in documenting those. They can support in the NTEP in evaluation of the newer initiatives, publications, as well as dissemination of these results. Finally, transfer of knowledge is very, very crucial. Okay, there are areas like PMJY, ECHS, EGHS, empanelment, NABL, NABH, accreditation processes that can be leveraged for TB program. At the same time, the TB-PPP initiatives can give benefit to some of the other initiatives like NCD program, NPCDCS, NVDVCP, and nowadays the surveillance programs. So you are the bridge between these different programs. TB program keep working on certain areas and certain ways, while you are the one who can bring all this in one table and have the exchange of the learnings from each of them. I'll stop here and we'll be ready. We'll be more than happy to answer any questions. Thank you so much.
Thank you, Dr. Bhavin, for sharing your valuable experience. Now I request Dr. Vijayashree Jayalappa, who is heading the India chapter of TB-PPM. She has vast experience of not only grassroots level, but working up to also NITI Aayog level. So over to Dr. Vijayashree, please.
Thank you, Dr. Bhavesh. I'm joined by my colleague from McGill University, Canada, Petra. Petra, may I have the slides, please? Yeah. So just a brief introduction of the TB-PPM Learning Network. It's an online community of TB-PPM practitioners. We have a mandate of nurturing a dynamic exchange of TB-PPM expertise and the best practices in the private sector engagement. That's our mandate. So this TB-PPM Learning Network originated at one of the union conferences, and India chapter specifically is an offshoot of the global network, which is present at the McGill University. This learning network started in May 2021. Currently, I'm leading this. We have assisted by a group of team of people. Under the, we have a vibrant governing board who advises on the activities that should be carried out. So I call upon Petra, my colleague, just to tell us how did this whole TB-PPM Learning Network came into existence. Over to you, Petra.
Thank you. Can you hear me?
Yeah, we can hear you. Go
Perfect.
on, Petra.
Okay, thank you so much. I'm really pleased to be present here with you all, and thank you so much for attending this meeting. Just to outline a few steps on how the TB-PPM Learning Network was started in 2019. As you might be well aware, we have for many years already experiences on engaging with the private sector, and WHO has for over 20 years documented a wealth of information on engagement with the private sector. And there is a PPM working group under the umbrella of the Global Partnership to Stop TB. That PPM working group has been looking at public and private mixed models. And in 2019, that group realized that really there's so much happening in this field around the world that the importance of PPM needs to be beyond the once year meetings. There is a need for documenting various activities. There's need for engaging. There's needs for cross-learning. And there's not enough people that actually bring the PPM stories to the global area. So that was a reason why this network, this PPM Learning Network, was started in 2019. And as you see, this is now 3 years in. We've grown rapidly with membership mostly from high TB burden countries, a large interest in India and Nigeria, which was a reason why we started looking at national chapters, where we realized that the work of PPM is really at the front line. That is where the healthcare workers are, and therefore the connection at country level is much more important than only in the global sphere. So the country chapters are the key of driving the action forward. I want to just share with you the framework of As you all know, and you've heard in all the presentations, our vision is to make sure that we can provide quality TB care for all people by all healthcare providers. And you've heard from various presentations on the myriad of healthcare providers that we're talking about when we talk about engaging the private sector. We have some guiding documents, which you see in the corner, a landscape document and a roadmap that provide us the framework for our work. And as part of the learning network, we work within a circular system of knowledge where we initially look at pulling the learning in from countries and from organizations that are actually on the ground. So that we take the learning from the action. And that learning is then synthesized into knowledge products, whether it is feature stories that are case stories where we write up different models or different activities, op-eds, reviews, articles, and that material is then provided to the larger community or actively tailored to different countries' interests through webinars, through different discussion forums. We have a TB-PPM course, and we also do interactive field visits. And then the next layer, we go into pushing the learning out through social media, newsletters, and in global conferences. And through all of that, when we look at prioritizing that learning, the cross-learning actually helps us to then bring different specific lessons to new policies or adapt it to the local context and in adjusting our programs and plans and adapting into the data as well. So this circle is a continuous circle within a country, between different states, between different districts, but also between different countries. Just to show you one example, we've now, over the last 3 years, we have developed over 30 feature stories from around the world. And we invite you to come and see these different feature stories to learn of models of activities happening within the different sectors, whether it's the laboratory, informal providers, pharmacies, or with different healthcare provider models. Just to give you a highlight on the webinars that we've been doing, different management products, knowledge management products, and a course that we have started, which is currently being further developed into different places. And then I would like to hand over back to Dr. Shri for more details on the India network.
Yeah, thanks, Petra. So this was the history with which this TB-PPM India chapter came into existence. And what are we doing here in this country chapter? We have one value proposition. We have a diverse private sector, as discussed by our previous colleagues. And then we have a complex ecosystem also to get them into realize the public health goals as envisaged by NTEP. We have 4 activities. One is, how do we empower NGOs or the private organization? It could be labs, it could be private practitioner, or it could be a chemist. How do we empower them? So what are we doing is, we are building the connections among the different PPM implementers, and we are providing a platform to learn from each other. So that is the approach that we have taken to empower these private organizations. And second activity that we are pursuing is that we have been talking to several stakeholders, and we have been collating the targeted learning opportunities. And we have been conducting several webinars after identifying these learning opportunities. Further, we are also making efforts to strengthen the PPM ecosystem. How are we doing this? We have a dynamic exchange of learnings, and we have been facilitating the interactions. And we position this TB-PPM Learning Network as a neutral platform, which identifies the learning opportunities and crafts responsive knowledge products. And all these activities are aligned with NTEP priorities, with the overall goal of eliminating TB by 2025. Next slide, Petra. So when we started, we did not really have the landscape of who are these NGOs who are capable of applying for PPSA, as explained by Dr. Bhavin and Dr. Swati. So we started creating a brochure and we reached out to various NGOs who will fit into the criteria of becoming a PPSA. And now for last 1.5 years, we have created a directory of potential NGOs who are around 350 in number, spread across the country. And we have been interacting with them, and we alert them whenever there are opportunities for bidding for PPSA. Next slide, please. And when I say peer-to-peer connections, how are we doing this? First one is consultative meetings. Since we have this PPSA arrangement to involve the private sector, we wanted to hear how the PPSA agencies in terms of NGOs or the private sector are able to implement this PPSA. And we conducted a webinar and we collated the challenges and enabling conditions. After hearing their concerns or the positive aspects of this whole PPSA, then we reached out to the NTEP managers and we spoke to them that how is this PPSA is actually helping them engaging with the private sector. There were a couple of suggestions on how do we amend the PPSA guidelines, and also on what are the enabling environment wherein some of the NGOs were really able to perform well. So all these learnings has been collated, and we have shared it with Central TB Division for the needful. So here we are acting as a knowledge broker between the National TB Elimination Program and the NGO sector. For that matter, the TB-PPM implementers. And we have within the TB-PPM website, we have an India website where the implementers are sharing the posts, the opinion. We have a Friday, people come and they discuss the various issues. And it has been found that this is one neutral platform where people can come and voice their concerns and also learn from each other. And when we speak to different stakeholders, we are also seeing that there are been some wonderful innovations happening. And we are trying to document this as a feature stories, and we do publish it in the website. And I urge all of you that if there are certain feature stories that worth of publication, please reach out to Dr. Modi, and we will be sharing our credentials as well. And there is another one, mentor-mentee program. We also see that when we were analyzing the landscape, we saw that there are some NGOs who are really well accustomed to the ecosystem and they know how to navigate the system. And also there are few new NGOs who are still learning. So what we are doing is we have matched the older NGOs with the newer ones so that they can learn from each other. And then we have a WhatsApp group where we are enabling the peer-to-peer connections, and it's another way of facilitating the peer learning. So in this whole activities, what we are doing is we are interacting the whole gamut of PPM stakeholders, right from the policymakers. We have the additional Deputy Director General, Dr. Matu, in this webinar. He has been quite proactive in facilitating this learning activities. And we have implementers, Dr. Ramya spoke, and Dr. Mishra was there, who's an STO, who has done an exemplary work. And we have researchers. So we have a whole gamut of stakeholders with whom we have been interacting and identifying the learning needs. And next slide, please. And in this process, we are also producing some of the knowledge products. Two of them I would like to bring to your notice is two webinars that we conducted. One is on, many of the NGOs wanted to know, how does this contracting mechanism work? How do we link this private healthcare providers to TB care? And we had called some of the experts in contracting. And the second thing was, many of the implementers in the TB-PPM domain are from the NGOs. Now it is high time that we also include the commercial organizations. That's how we had invited some of the people who had worked in other national health programs, who are the commercial organizations, and take their suggestions on how do we also engage the commercial organization, TB care and management. In the same vein, we also realized that the implementers said that, it is very difficult to access the resources for learning anything about TB-PPM learning or any material. So we came out with a repository. It has been hosted in the TB-PPM Learning Network India chapter, where we have deposited all the materials related to TB-PPM. That could be reports or gray literature, publications, guidelines, and so on. And there was a suggestion from Central TB Division and also the governing board members that there are so many things happening in the country, wonderful opportunity to document all these models. That's how we prepared a compendium of all the TB-PPM models that is in operational or complete in last 1 decade. And this is under the review, and very soon, once the CTD approves it, we will be making it, putting it in the public domain. Next slide, please. And we also realized IAPSM is one agency which has been heavily contributing to NTEP, and we did not want to miss this opportunity to collaborate. And we reached out to IAPSM a couple of months back, and Dr. Bhavesh and Dr. Purushottam Giri, and we discussed on the opportunities where we could jointly work together and build the capacity of the stakeholders, mostly at the district level, where people are implementing the TB-PPM. Many a times, the implementers may not have a bandwidth of documenting the best practices, or the DTOs may be willing to write an abstract for a conference or even the manuscript. So that is where we thought there is a knowledge gap, and there is a gap where we can actually work as a knowledge broker and bring the DTOs and the NGOs and the IAPSM members together, and we can start working towards the goal. Essentially, what we are trying to do is that produce knowledge products and facilitate the peer learning. And we signed an MOU on the 31st of August 2022. And I'm very thankful. I take this opportunity to thank Dr. Bhavesh Modi for taking this forward, and Dr. Purushottam Giri. We had several rounds of discussions, and here we are today. And once we come out with a kind of roadmap, I would request the IAPSM leadership to come out with maybe a small group of experts, and we could chart out an action plan. Next slide. This would be my next slide. And I thank you, all of you, for joining this webinar. These are our credentials. And the registration to this TB-PPM community is free, where you could start posting their opinions and any of your best practices. And you could also reach out to us on email, and we have a Twitter handle as well. Thank you so much. Over to you, Dr. Bhavesh.
Thank you, Dr. Vijayashree, for sharing the details about the TB-PPM network and our collaboration also. So we are already late by, I think, 10 or 12 minutes. So without wasting much time, we are opening for the panel discussion. And quickly, I want to ask Dr. Ramya about, because she is herself has done community medicine and teach at the medical college and working very closely with the community. So how can we move this forward? Dr. Ramya, your inputs for this collaboration, next steps.
Thank you. I think IAPSM could definitely have a great role in working with the PPSA, especially supporting them, providing technical support, right, in terms of building a good proposals, helping in developing the monitoring and the evaluation framework, and also supporting the actual rollout of the program, and supportive supervisions, and maybe evaluations, because I think many times it's also important for PPSAs, once they roll out the program, to get feedback both from the private sector and people in the private sector. And that's where IAPSM can be an independent body helping to be that bridge between the private sector and the public sector, supporting the PPSA. So I think this is one very specific area that I could think of. Thank you.
Thank you. Thank you, Dr. Ramya. Next quick question is again for Dr. Bhavin, because he has also, I remember when he finished his MD community medicine, he started with the Leprosy Network of India and started working at that, and then in faith-based organization, then in WHO, and now in USAID and FIND. So he has also very vast experience of working at different levels and with different stakeholders. So Dr. Bhavin, please give your inputs about possible next steps, how we can leverage on existing collaboration.
Thank you, Dr. Bhavesh. I think some of the points that I highlighted, I'll re-emphasize, and I largely spoke about PPSAs, but frankly speaking, there are a lot of development projects which are running on the district and the state level, and majority of them try to bring something new as compared to what is conventionally being implemented. I think so. There is a huge scope of working together and taking those innovative initiatives to the next level. Right. I'll just to name a few. Dr. Ramya's project is working on completely on the community aspect of patient care, quality of care, quality of life during as well as post-treatment. The artificial intelligence solutions being implemented by other partners. There are partners working on particularly on the tribal and the urban communities and the comprehensive primary healthcare. There are organizations who are working on the digital training solutions. I think so. The scope is huge. There are almost 20-25 states where these different projects are running in, including public-private partnerships. So the areas where the IAPSM can bring value is of course the capacity building process, but at the same time all of these newer initiatives require assessments, whether it is a baseline or midline or endline assessments, which are very crucial in terms of documenting the success or the failure, whatever the learnings may be. So I think the learning is the key area where the colleagues can help us and documenting, publishing, and disseminating the results. And of course the other areas that which are particularly concerned with the PPP is all about this cost and cost effectiveness analysis, right? So there are small projects and pilots keep running in, but at the end of the day, whether it are cost effective or not, or these are scalable or not, it's a useful insights and the guidance that can be there from the community medicine colleagues.
Thank you, Dr. Bhavan. Dr. Shri?
Yeah. I was planning to just ask Dr. Mattu. Sir, thank you very much for joining this webinar. Sir, are you there? Dr.
Yes.
Swati,
Yes,
Dr. Mattu.
yes, Dr. Vijayasri. Yes.
So the NTEP has made a great progress in engaging the private sector in TB care. Sir, according to you, what are the PPM priority areas to move towards the goal of TB elimination? And how this collaboration between TB-PPM Learning Network and IAPSM could contribute to the goal of eliminating TB by 2025?
Thank you, Vijayasri, for asking these questions. When we are concerned with the private sector engagement, it is very crucial and important area for National TB Elimination Program. If we see as a program division how we are providing the services for the persons or the patients who are suffering from the tuberculosis, we are providing best of the diagnostic services, which include the NET, LPA test. Then we are having liquid culture, DST services also. We are providing best of the therapeutic services, like we are having fixed dose combinations, and then we are having best of the medicines which are there for the DrTV. we are having all such medications available under the program. We are having active case finding also to find out some of the cases which are available in the community. So these are the some of the activities which the program division is already doing. So at a public health level and the public health sector, we are doing many activities, and we are reaching towards a saturation point. Now there are the a certain important area which are left out, like a public health sector engagement and the TB preventive aspects, where we need to give the more focus if we really want to achieve our NTB target. Already during the course of this webinar, Swati, Bhavin, they have highlighted like what are the different mechanism through which we can engage these private sectors. Like we are having carrot and stick approach, where we are providing the incentives to the private sectors. Then we are having stick approach, where this Swati highlighted that we are having some legal positions, notifications and be there, and then the rule positions are there which are making the notification mandatory also, and some imprisonment. So these are the some of the things. Now coming to other than this, like what have been the enabling environment. So in the program division, we are having a certain aspects, like we are having a partnership guidance document on which Bhavin had a detailed session. Then we are having this PPSM mechanism also, which acts as an enabler. And I'm proud to say that when we are having this partnership schemes, where we have moved from the referral from the private sector to the public sector, and now we have moved to the partnership with the private providers, where we are putting private providers on equal footing. We are respecting them. We are recognizing their clinical acumen also, and we respect that whatever services they are providing. So we have moved towards this. And I'm proud to mention that 2 to 3 weeks back, we were in the Kenya, where this world over the different country was participating on this public-private mixed workshop was there. In that, India was the only country where we have moved ahead from the partnership-led financing to the domestic funding, which is the sustainable model, where this government of India's commitment has been appreciated by world over countries, that yes, we are moving to the government funding, and that is how we are committed also. We want to make this private sector engagement. Now coming to the your questions, like what are the different priorities for the PPM, which program division is looking for. So first of all, we are having this private health care providers, where we want to have identification and mapping of all the private healthcare providers. This is one of the very important area. Like we are having list of the big corporate hospitals, but other than this, we are having other allopathic doctors who are working either in the nursing homes, or we are having the small standalone clinics are there. Then we are having some less qualified doctors also, and which we call the informal health sectors. Then we are having Ayush sector also. So these are some of the health sectors where we need to identify all the this health service provider who are working in particular geography. They need to be identified and they need to be mapped. While program is providing this free diagnostic and treatment services, this less qualified providers or the Ayush doctors is an area we would like to focus to own, so that our patient not just get the quality services, but also get it as early as possible, to ensure that there is no delay in the diagnosis and treatment. Other area where we want to prioritize is the partnership area, where we want to have this partnership, and how this partnership can be enabled and strengthened. So like if we are seeing this PPSA mechanism, we are having as of now 385 districts have been approved for this mechanism. But if we are seeing this, only 50% are functional at this stage. So how this engagement of the procurement service of the PPSA may be done in the expeditious manner, that is another area we need to focus. There are the certain areas, like if the PPSA is there, the payment issues are there, how we can smoothen and make the payment at the earliest, that is another area we would like to focus. Other than this, when we are looking for the partnership, we are having this TB preventive aspects also. Like private sector, they are concerned, they are more focused on this clinical approach and just focus on the treatment of the patient. But we want to get their involvement and their support for the TB preventive aspects also, where this contact tracing of the family members may be done, and all the eligible persons may be provided the TPT. Then other area where we may have this is a TB Mukt Bharat Abhiyan. Basically, it is a Pradhan Mantri TB Mukt Bharat Abhiyan. It was launched by our honorable president also. And we want to see that how this community may be mobilized through this private sector engagement, and they may come up with support where this will, along with the generation of the awareness, it will provide some community support also, and this social stigma discrimination will be decreased by this approach. So this is another area. Now, how we see this association and collaboration with the IAPSM and the TB Learning Network. So when we are having this, both the organization IAPSM and the TB-PPM Learning Network, they can act like a catalyzer and the enablers, where both parties have their own expertise, their own strengths. IAPSM has a huge network of the doctors which can assist with their technical expertise in terms of the need assessment and monitoring. They are already supporting in the subnational certification, and they are basically having reach to the health service provider which are working at the peripheral level, where because they are having the regular contact, and they are in touch with the primary health centers as the part of the PSM activities and the curriculum. So we can have the learning from this IAPSM, how we can engage this peripheral health service providers, and the primary health care can be considered with regard to the private sector engagement. TB-PPM Learning Network is already providing a network of the professionals who are associated in the partnership. And if I'm seeing the both the organizations and other the stakeholders, so it may be quite right to mention that all the stakeholders which are associated with this PPM has played an important role in making PPM in NTP as we are on today. So these are the some of the points which we have kept as a prioritization, and I am hoping and looking forward that collaboration and association with both the association and the networks, we can achieve some of the good heights and can move towards ending TB and achieving this NTB target at earliest possible time. So this was some of the priorities, and thank you, Vijayasree. Over.
Thank you, sir. Dr. Bhavin, I have one question for Dr. Chopra, and maybe then I'll hand it over to you if Dr. Giri is not there. Yeah. Dr. Chopra, thanks for joining, and thanks for leading this webinar and guiding us. So this IAPSM has been involved in NTEP, as told by Dr. Mattu, and contributing heavily towards the goal of eliminating TB. So what are your thoughts on taking this collaboration forward? If you could suggest us a few actionable points which we could pursue in the coming months. Over to you, Dr. Chopra.
Thank you. Thank you, Dr. Shri. Since TB-PPM is an online network, so I jotted down a few of the points. Of course, it will be a repetition of what the various people have said, but then I jotted a few points, and I'll be talking about those points. And these are all doable interventions which can be done. Of course, your area of expertise is only online, but then when we are talking of ending TB, we have to go to offline, because everything cannot be achieved online. Online, yes, you can do trainings, and basically because you are providing the knowledge network, so you have to then do training at the district level. Each district you must involve and involve the stakeholders, like you can involve the IMA, you can involve the IAP, you can involve the physician bodies. So if you can involve and then provide them the training, because there are a lot of people who are still not knowing the standard treatment guidelines and the changes which have taken place. Number 2 point is that, yes, another thing is that monitoring supervision already has been talked about, gap identification, implementation, operational research, active case finding. But most important than that is you have to do a mapping of all the resources as far as the diagnostic services are concerned. I'll take 2 minutes and tell you a real life story experience. I was sitting in a radiological diagnostic center for the investigation of one of my relatives, and I saw a child brought by the mother for doing the FNAC of the cervical lymph node, right? Most probably the treating doctor, the treating pediatrician was thinking that it is tubercular in nature. Now, for this FNAC, the beneficiary has to pay 1,000 rupees because it is to be done under ultrasound guidance. Once he took out the aspirate, then he said that now I have to send this sample for CBNAT. And where he'll send it? Naturally, it is a private sector. He'll send it to a private pathologist. He said for this, you'll have to deposit 4,000 rupees. So point is this, yes, we are trying to provide services, but then we have to provide knowledge to each and everybody that these services are available free of cost. Now, look what has happened. The mother has already spent 5,000 rupees and we are not sure whether it will come out to be positive or negative. So this is the ground reality. So mapping of resources is one thing which is important, but more important than that is that you have to disseminate. And online you can do it. You can put it on your website, district-wise, what are the facilities which are available, where they are available, what are the timings where they are available. Because until and unless the providers, they know that there are services which are provided free of cost, and only then you can mitigate the suffering of the beneficiary. That is important. And yes, mapping of all stakeholder is again important, as talked by the REACH people. Then one thing which is missing is that, yes, we are collecting a lot of data, but the data analysis part is again very, very important. And nobody is doing that data analysis. And this cannot be left upon only to the IAPSM or to the TB-PPM network. We need to have the IT expert here. We have to pitch in. You have to do the data analysis. Only then you will be able to find out the missing links, the missing gaps. Otherwise, it will not be possible. Then I've already talked about that you have to involve IMA. Sir has already talked about that you have to involve the alternative practitioners because they are the weakest link. You have to provide training to them. Maybe you have to take the help of their organizations as far as this thing is concerned. Then coming towards the end, yes, that is very, very important that all of you have talked about, highlighted the role of PPSAs. But what about the concurrent evaluation of the functioning of PPSA itself? Because until unless you do it, you do not know, you are pitching in so much of resources, whether they are giving you the good results or not. And I think the IAPSM will come in here because that concurrent evaluation will be of great importance to enhance the quality of the services provided by the PPSA. So that is again a doable point which can be think about, and Dr. Mattu is here. I think that he can take lead in that. Then the involvement of the CSR is already talked about. Now this one, last one is specifically for you, is create a digital platform to answer the queries of the private practitioners as far as the diagnostic and the difficult cases are concerned, because that is missing. That is nowhere. So again, you see, we are living in a world, it's a World Wide Web world, boundaries are not there. And since you are online network, if you can create that kind of a resource, maybe involving pulmonologists, maybe involving community medicine specialists, maybe involving good physicians, maybe people involved in treating tuberculosis, treating tuberculosis ground level, because that's entirely different phenomena. When you treat tuberculosis ground level, you treat tuberculosis in a tertiary level hospital, the case presentation, the type of treatment is entirely different. So that you'll agree. So, and last but not the least, a qualitative research is required. We have all talked about from the provider point of view. We have not touched what really the beneficiary wants. If we can answer that particular question, where what beneficiary want, where they want the services to be available, what kind of services they want, so that they come fast and report their symptom as early as possible, because that is the only way to prevent the occurrence of tuberculosis. Because if you can take care of the infector pool as fast as possible, then probably we'll be able to end tuberculosis by 2025. So these are my takes on what we can do, what are the doable actions. So you can note it down. And yes, you can call a meeting of the experts of IAPSM once again, and then step by step, you can chip in and involve all the districts. Basically, you'll have to involve all the districts. It's a huge task. India is a huge country. But then if there is a passion and a desire to work, nothing is impossible. I believe in that. Thank you so much.
Thank you, Dr. Chopra. I think these were very, very useful points. This is one of the first exploratory meeting that we wanted to have. And I'm sure Dr. Bhavish would take a lead, and we'll have consequently we'll have 2-3 meetings, and we form a small group of experts, and we'll chalk out a plan. How do we take this agenda forward? Thank you so much, sir. Dr. Bhavish, over to you.
Also, thank you all for contributing actively, and especially Dr. Harivansh Rai Chopra, sir, our President IAPSM, for his blessing, concluding remark, as well as way forward. Dr. Sanjay Mattu is also here. So I think sure, like SNC, we will continue working together towards elimination of TB in India. So let's close the session. Thank you, everyone, panelists, as well as the participants from across the India. Thank you.
And I would also just place my thanks to my colleague Petra from Canada. It was early morning. Thanks, Petra, for helping us with the logistics. Highly appreciated.
Thank you, Petra.
Thank you. Thank you, Dr. Chopra.
Thank you so much.
Dr.
Thank
Sri
you.
and Dr. Modi. Thank you. Thank you, Bhaven.
Thank you, sir. Thank you, sir.
Thank you, everyone. Interesting and insightful discussion. Thank you.
Thank you, sir. Thank you.
Thank you. Thank you very much.
You stay back. You stay back.